Hello, my name is John Madar. As Chair of the Guidelines Writing Group for 2021, it's my pleasure to present to you the Newborn Life Support Guidelines for the European Resuscitation Council. The Guidelines Writing Group comprised 13 individuals from around Europe, all with an interest in newborn resuscitation. The guidelines represent the culmination of some months of activity reviewing the evidence and developing new recommendations for guidelines where the evidence suggested that there was evidence for change. As clinicians involved in newborn resuscitation, we all have other areas of involvement, but we do not feel that these have influenced our ability to develop these guidelines. These guidelines build upon previous publications, the 2015 guidelines being the last iteration, where the evidence suggests that there are elements which may be changed, then recommendations have been altered. Where there is no evidence for change, recommendations remain largely the same. These guidelines are now available for review and incorporation into clinical practice. The format of the guidelines has changed. There is a summary of the new recommendations where these have altered. There is now an infographic available separately via the ERC website, which provides a summary of the key changes in a pictorial format which may be used for education or clinical practice. The algorithm has been revised, and the guidelines themselves are in a concise guideline for clinical practice, followed by a section with the evidence. So the infographic provides a summary of 5 key domains, and then there are 5 separate sheets expanding on the information relevant to the key domains. The algorithm is altered from the previous version, but retains a similar approach with a linear section where the recommendations are phrased and advisory elements around the side. A new domain here provides information on the altered management for the preterm baby. So using the algorithm, we will now go through the recommendations for resuscitation of the newborn. Initial steps are unchanged, with a suggestion for antenatal counselling where this may be undertaken, recognising that it is not possible to predict in all cases when resuscitation or stabilisation is required. Team briefing is considered good clinical practice and equipment check vital. At birth, we now suggest that delayed cord clamping should be undertaken, recognising the advantages for the preterm baby in particular, with improved outcome and reduced morbidity, but also for the term baby. Thermal care is considered vital. Again, dry wrap and keep warm. For the preterm baby, in the preterm advisory box for babies under 32 weeks, we suggest placing undried in a plastic wrap with radiant heat where facilities permit. Stimulation may improve respiratory effort and oxygenation. The importance of temperature is highlighted through an imperative which runs through the whole algorithm. Assessment is unchanged, reviewing tone, breathing and heart rate, recognising that floppy babies are likely to need help and that inadequate breathing requires help. Heart rate is a marker which indicates the adequacy of oxygenation, with a fast heart rate indicating satisfactory oxygenation and a slow heart rate suggesting low oxygen levels. A prompt for help indicates the need to review this at all times during the resuscitation process. Initial airway support is through opening the airway. For the preterm baby who are breathing, CPAP is considered with a prompt in the algorithm to this effect, recognising the benefits of CPAP in reducing respiratory morbidity. Where the baby is gasping or not breathing, 5 inflations should be provided for the term baby at 30 centimetres of water, and for the preterm baby now 25 centimetres of water. The lower margin of 20 centimetres of water has been removed after review suggests that this would be effective in sufficiently aerating the lungs. Starting concentrations of oxygen should be air for the term baby, and for the preterm baby under 32 weeks, between 21 and 30% for those between 28 and 31 weeks gestation, and for those under 28 weeks gestation, 30% oxygen should be the starting concentration, recognizing the need to achieve sufficient oxygenation. Monitoring of oxygenation and heart rate is promoted using saturations and/or ECG. Once again, there is an advisory box with the recommended ranges of target ranges of saturations to aim for. This has been simplified to just 3 values, that at 2 minutes, 65%, 5 minutes, 85%, and 10 minutes, 90%. That at 5 minutes of 85% is particularly important, acknowledging the evidence that suggests that saturations of over 80% are required by 5 minutes, because to be under this is associated with a poorer outcome. If, following initial inflations, there is no increase in heart rate or chest movement, an advisory box provides prompts to actions which may be undertaken to improve matters. Once again, there is an emphasis on airway positioning and checking that the mask is being applied correctly. Other manoeuvres that may be considered is that of 2-person support, recognizing that this is superior to single-person airway management, and where particulate matter may be felt to be a factor, inspection and suction under direct vision. For the first time, the laryngeal mask and tracheal tube are included in this section, recognizing that these may be valid ways of achieving an airway where mask support is proving unsuccessful. Following any repeated manoeuvre, there should be repeat inflations, repeat assessment, and when the chest is moving, ventilation at 30 breaths per minute. If, following achievement of aeration and chest movement and 30 seconds of effective ventilation, the heart rate remains either absent or very slow, i.e. less than 60 per minute, chest compressions should be commenced. These remain at 3 chest compressions to 1 ventilation, 15 cycles per 30 seconds. It is now suggested that the oxygen should be increased to 100%. In a situation of chest compressions with a complicated resuscitation, it is also now acknowledged that securing the airway is a manoeuvre which should be undertaken with consideration given to intubation if not done already, or for a laryngeal mask if intubation is not possible. Where resuscitation is ongoing and response is lacking, vascular access should be sought. The umbilical venous route is felt to be the most optimal route, but intraosseous access may be considered where a UVC cannot be inserted. Drugs to consider include adrenaline, now in a dose of 10 to 30 micrograms per kilogram IV. This may also be given intratracheally if there is no vascular access, in a dose of 50 to 100 micrograms per kilogram, with an intravenous dose given as soon as venous access can be secured, irrespective of the time interval between the tracheal dose and the vascular dose. Glucose may be given in a dose of 250 milligrams per kilogram, that's 2.5 mils of 10% dextrose, recognizing the potential for hypoglycemia in the prolonged arrest. Where volume loss is felt to be significant, volume may be given either as blood or isotonic crystallide in a dose of 10 mils per kilo in the first instance. Bicarbonate may also be given, but this is not universally recommended. In the algorithm, there are now prompts for situations which may be prolonging the resuscitation and leading to a lack of response, such as pneumothorax, hypovolemia, or congenital abnormality. Whatever the outcome, it is recommended that parents must be updated on the situation and any concern. Where a baby is not responding, and failure to respond despite 10 to 20 minutes of intensive resuscitation is associated with a high risk of poor outcome, it is felt appropriate to consider discussions with the team about withdrawal of treatment and with the family. And if there's been no response despite the provision of all recommended steps of resuscitation and having excluded reversible causes, an interval where these actions may be considered is felt to be around 20 minutes. So the priorities of newborn life support remain unchanged, those of optimising condition at birth with delayed cord clamping, good thermal care, priority to airway support, lung inflation and ventilation. Rarely are chest compressions and drugs required. A fast heart rate is the marker of effective oxygenation. Saturation monitoring is promoted to provide information on the heart rate and oxygenation, and with any resuscitation or complex situation, good communication and teamwork are essential. I hope that these guidelines prove to be useful. Thank you for your attention.